Hey fellow lab rats, this is Rebecca from the Lab Rat YouTube channel. In this video, I'm going to be lecturing on anemias of disordered iron metabolism and heme synthesis. All right, let's get started. Iron has many roles in the body. It helps in oxidative metabolism, cellular growth and proliferation, and of the transport and storage of oxygen. There's a pigment called protoporphyrin 9 that reacts with iron that converts it into heme. And heme is a part of hemoglobin. So with low levels of iron, you're going to have low levels of heme, and then of course low levels of hemoglobin. So iron, of course, is critical for the synthesis of hemoglobin. The total concentration of iron in a normal human body is around 40 to 50 milligrams, and around 20 to 25 milligrams of iron is needed every day to maintain a normal population of red blood cells in the peripheral bloodstream. There are two categories of iron-containing compounds within the body. Functional compounds are enzymatically functional iron, and iron that is in a transport or storage form. About 2/3 of the iron in the body is used for hemoglobin production. 1/3 of it is found in the spleen, marrow, and liver in transport and storage forms. Transferrin is a glycoprotein that's synthesized in the liver, and it binds to iron and transports it through the blood. Lactoferrin is another glycoprotein in the transferrin family that is present in secretory fluids like milk, tears, and saliva. It binds and transports iron as well. The storage forms of iron are called ferritin and hemosiderin, and I will discuss those on the following two slides. Ferritin is the primary storage form of iron found in the liver, bone marrow, and the spleen. It is readily available for use in case the body experiences blood loss. It decreases early on in iron deficiency disorders, but increases in conditions of iron overload. It is what we call an acute phase reactant, which makes it an unreliable indicator of iron stores in the body if the body has increased inflammation. I talk about acute phase reactants when we are discussing CRP and clinical chemistry, but also the sedimentation rate is an acute phase reactant. Well, so is ferritin. So acute phase reactants are going to be falsely elevated when the body has inflammation present. Hemosiderin is also a storage form of iron found primarily in the macrophage. It is a complex of carbohydrate, lipid, protein, and iron. Unlike ferritin, which is readily available for use when blood loss occurs, hemosiderin is not. It is slowly released, and hemosiderin stains yellow to brown. Iron deficiency anemia, or IDA, is the first type of anemia that I will be discussing in this anemia lecture. A deficiency of iron is actually the most common nutritional deficiency in the world. In underdeveloped countries, IDA develops because meat is scarce. If grain is the main dietary source, it's common for IDA to develop. The parasitic worm called hookworm is common in underdeveloped countries as well. These parasites feed on blood from the intestinal wall, and blood loss can cause IDA. Now, in developed countries, because it does happen in developed countries as well, the number one cause of IDA, specifically in older men, is chronic gastrointestinal bleeds or GI bleeds. This is also relatively common in premenopausal women that have excessive menstrual bleeding. So what causes iron deficiency anemia? A poor diet, so a diet that doesn't provide enough iron. So iron is found in meat, fish, and poultry. So again, people in underdeveloped countries that don't have access to these iron sources have an increased risk of developing IDA. Vegetarians also have an increased risk of developing it. IDA can also be caused by an increased need for iron. So an example of this would be in pregnancy. So the fetus has an increased need of iron as it's developing. And where does the fetus get that iron? From the mother, right? So this is common in pregnancy. Also in children that have a poor diet, they can develop IDA as well. Chronic blood loss can also cause iron deficiency anemia. So this is little bits of blood lost over a long time, which adds up, right? So this can be in premenopausal women due to menstruation, which is blood loss, pregnancy, of course, a poor diet, which we've already discussed, and a chronic gastrointestinal bleed. There are 3 different stages of iron deficiency anemia. Patients with IDA do not start showing symptoms of it until the 3rd stage. So why do you think that this is? So remember in the Introduction to Anemia lecture how I said the body does everything it can to try to compensate for blood loss? Well, that's why. At the first 2 stages of IDA, the body is doing everything it can to compensate. So in terms of symptoms, so patients with IDA will have shortness of breath, dizziness, and fatigue. And this is due to not having enough oxygen being delivered to the tissues. The body is just trying to increase the output of the heart as well to increase the amount of oxygen that's getting into the tissues. So a higher workload on the heart can occur, including heart palpitations and something called tachycardia, which is an increased heart rate. Patients with stage 3 iron deficiency anemia can also experience glossitis, which is an inflammation of the lips and tongue, and something called pica, which is cravings for strange, non-edible things like dirt, and ice cubes, things like that. So let's talk about what we will see in the different stages of iron deficiency anemia. Recall the only stage symptoms appear is in stage 3 because that body is trying to compensate for the anemia. So in this first stage, iron stores will be depleted. So the stores will be depleted. They're all used up. There will also be a decrease in ferritin in the serum. At this stage, there is no anemia. Hemoglobin, iron in the serum, and transferrin are at normal levels. Just those iron stores are depleted. Red blood cell morphology is also normal. There may be an increase in red cell distribution width or RDW. At the second stage, remember we have no more iron stores from stage 1, and this causes there to be an iron deficient erythropoiesis. So iron is required for heme, and heme is required for hemoglobin. This can't be made if there is no iron. So ferritin and iron are going to be decreased in the serum. The bone marrow, if a bone marrow biopsy is performed, of course, has no sideroblasts. And sideroblasts are erythroblasts, so baby red blood cells that are iron engorged. The patient's hemoglobin will start to lower a bit, but anemia and hypochromasia are not present yet. Total iron binding capacity, or TIBC, is the measurement of the saturation of iron. This will be increased in stage 2 of IDA. This is because the body is trying to make more transferrin to help transport iron to help the body maintain itself. Now at stage 3 IDA, this is total functional iron depletion. TIBC is increased, ferritin is decreased, and obviously iron is decreased. So less than 30 micrograms per deciliter. So the normal is around 70 to 200 micrograms per deciliter. On the peripheral blood smear, you'll see microcytic hypochromic red blood cells. So this is a decreased MCV and a decreased MCHC. If you don't know what MCV and MCHC, those are red blood cell indices, check out my other lecture on red blood cell indices. So the red cells are going to be hypochromic because, of course, there's a reduced amount of hemoglobin because of the iron depletion. And why would MCV be decreased in this case? Why would there be microcytes? So hemoglobin makes up cell volume. So if you decrease the amount of hemoglobin, which is happening here, you're going to have a smaller volume of red blood cell, and the cell is just going to be smaller. So again, microcytic hypochromic cells. As the IDA develops, you start to see poikilocytosis, which is an increase in abnormal red cell morphology. So frequently target cells, elliptocytes, and dicryocytes will be present. If you don't know what those are, go ahead and check out my red blood cell morphology lecture. So at the last stage of IDA, you may find reticulocytes. White blood cell count is usually normal, but it can be increased. Platelets can be normal, increased, or decreased, but are frequently decreased with IDA. In terms of laboratory findings, an important test for IDA is serum ferritin. Serum ferritin will be decreased in iron deficient anemia patients. This helps to distinguish it from other microcytic hypochromic anemias. As anemia of chronic disease will have normal to increased levels of serum ferritin, and it will be increased in sideroblastic anemia. Serum iron will be decreased, and TIBC will be increased in patients with IDA. Transferrin receptors will be increased in patients with IDA because, again, the body has been trying to compensate for the lack of red blood cells present. If the iron deficiency anemia is secondary, meaning something is causing the iron depletion, like pregnancy or blood loss, the treatment for it is to correct that secondary cause. So in cases of pregnancy, once the mother delivers the baby, she will no longer have an increased need for iron. If blood loss is the issue, once the bleeding is stopped, iron will no longer continue to be depleted. If the cause of the iron deficiency is primary, iron supplements can be given. For primary reasons of iron deficiency anemia, the success of the treatment of supplements should be checked. The patient should have an increase of their hemoglobin levels around 1 gram per deciliter per month. The next anemia I'm going to be discussing is anemia of chronic disease, also called anemia of chronic inflammation, or ACD for short. This is an anemia that occurs in the presence of an underlying disease. This is due to an inability of the body to use iron for the production of hemoglobin. There is no bleeding, hemolysis, which is the lysing of red blood cells, or marrow involvement in this type of anemia. This is the most common anemia in hospitalized patients and occurs in those with chronic infections or inflammatory disorders, trauma, failure of one or multiple organs, or neoplastic disorders, which is cancer. In this type of anemia, the patient will have low iron levels in their serum, but have normal stores of iron. The marrow macrophages will have increased stores of iron. As it's written here, this implies that the iron is not being transferred from the macrophages to the developing red blood cells. Erythropoietin, or EPO, is decreased as well. I discussed EPO in my erythrocytes lecture, but in short, this is a protein hormone that is responsible for the production of red blood cells. Additionally, the red blood cells have a shortened survival within the peripheral bloodstream. Patients with anemia of chronic disease have a mild anemia, so around 9 to 11 grams per deciliter hemoglobin level. Normal hemoglobin levels for men are 14 to 17.4 grams per deciliter, and for women 12 to 16 grams per deciliter, just as a reference. So mild anemia is going to be 9 to 11 grams per deciliter. Serum iron is decreased. TIBC levels are either decreased or normal. Iron saturation remains unchanged or can be decreased. Serum ferritin levels stay normal or can be increased. And again, ferritin is a great way to differentiate iron deficiency anemia from anemia of chronic disease. Remember, in IDA, the serum ferritin level is going to be decreased. Sideroblastic anemia is an anemia that is caused by a block in the protoporphyrin pathway of hemoglobin synthesis. Protoporphyrin works with iron to form heme, and heme reacts with globin to form hemoglobin. In sideroblastic anemia, there isn't protoporphyrin. This results in a large iron overload. Patients are going to have an increase of total body iron. They will have ringed sideroblasts present in their bone marrow if a bone marrow biopsy, of course, is performed. Sideroblasts are erythroblasts that are iron engorged. And ringed sideroblasts occur when all the extra iron accumulates in that erythroblast and it encircles the nucleus, looking like a ring around the nucleus. So in this picture on the right hand side of the slide, this is a smear from bone marrow that's stained with something we call a Prussian blue stain. With a Prussian blue stain, iron kind of lights up like the 4th of July. It's like super bold, bright blue color, and you can see all around that nucleus there. There's just like, iron all around, kind of in a ring-like. So that's what we're talking about. If you ever hear Prussian blue stain associated with iron. Now, patients with sideroblastic anemia will have microcytic hypochromic red blood cells within their peripheral bloodstream, so a lowered MCV and MCHC value. And again, if you don't know what MCV and MCHC are, check out my red blood cell indice video. Now, there are 2 classifications of sideroblastic anemia: hereditary and acquired. Hereditary is, of course, genetic. It's inherited in a recessive sex-linked manner. I'll discuss this more on the next slide. The acquired classification means that there is no genetic component to it. The patients just acquired it at some point in their lives. There can be idiopathic reasons, which means it arises spontaneously with no known cause. It can be secondary to certain drugs or toxins, or it can be associated with cancer. So let's talk about these classifications. So I mentioned one of the classifications of sideroblastic anemia is hereditary, meaning it's genetic. It's due to a recessive sex-linked gene. It mainly occurs in males, and the reason for that is that it's X-linked, which means that the mutation is in the gene on the X chromosome. Genetic males have one X and one Y chromosome. So if a genetic male inherits the mutation on the X chromosome, there's only one X chromosome that's going to be expressed. So if they have that mutation, it's going to be expressed. You're going to see it. Now, if a genetic female has that mutation, so they have two X chromosomes. So one X chromosome would have that mutation on it, and the other one would be normal. So it would not be expressed because that gene is recessive. So this is why we usually only see it in genetic males. So again, sideroblastic anemia is an anemia that is caused by a block in the protoporphyrin pathway of hemoglobin synthesis. So the most common reason for this is a defect that's due to an abnormal ALAS enzyme. Protoporphyrin works with iron to form heme, and heme reacts with globin to form hemoglobin. So in sideroblastic anemia, there isn't protoporphyrin, and this results in a large iron overload because that protoporphyrin pigment, I believe it's protoporphyrin 9 pigment, reacts with iron to form heme, and then heme reacts with globin to become hemoglobin. So if there isn't protoporphyrin to react with or combine with that iron to form that heme, there's just going to result in a large iron overload, way too much iron. And also because the body isn't able to form hemoglobin, ineffective erythropoiesis is going to happen, which of course causes the anemia. If we have a reduced number of red blood cells and a reduced number of hemoglobin, we're going to be anemic. Two acquired reasons for the development of sideroblastic anemia are lead poisoning and alcoholism. Now, lead competes with iron in the body, and iron, of course, is important for heme and hemoglobin to be made. So when high levels of lead are in the body, this is going to compete with the iron and it's going to disturb the production of hemoglobin. And of course, this results in a ton of iron accumulating in the cells. Patients with lead poisoning may also have basophilic stippling present in their red blood cells, and I included a picture of this here to remind you what it looks like. For more info on basophilic stippling, please check out my lecture video on red blood cell morphology. Now, alcoholism is another acquired reason for the development of sideroblastic anemia. Alcohol is toxic to hematological cells. Now, it's difficult to interpret lab results from patients that have this. There can be macrocytic red blood cells, so an increased MCV indice. The red blood cell population can be something that we call dimorphic. Another term to describe this is a dual population of red blood cells. So there will be two different types of red blood cells. So in this case, normal red blood cells and macrocytic red blood cells. The patient has increased serum iron only when they are heavily drinking. Refractory anemia with ringed sideroblasts, or RARS, is a type of myelodysplastic syndrome. These syndromes are a group of cancers that prevent mature, healthy blood cells from forming in the bone marrow. RARS is a myelodysplastic syndrome that also has ringed sideroblasts in the bone marrow. Patients with RARS can sometimes have normocytic or macrocytic red blood cells, so either normal MCV or increased MCV indices. A dual population can also be seen. So remember, a dual population or dimorphic population means two different types of red blood cells. So in patients that have RARS, some of the cells can be normochromic and some of them can be hypochromic. So this slide is a summation of the things we're going to be seeing as laboratory professionals in patients that have sideroblastic anemia. I mentioned dual population or dimorphic populations of red blood cells. So you can have normochromic or hypochromic red blood cells. There can be macrocytic, normocytic, and microcytic red blood cells. Also, poikilocytosis will be present or can be present, which means that there are red blood cells present in the peripheral bloodstream that have abnormal morphology. You can see Pappenheimer bodies, target cells, and basophilic stippling. So please check out my separate lecture video on red blood cell morphology. Platelet levels can be unaffected or be increased. Serum iron, serum ferritin, and saturation are all going to be increased. And of course, ringed sideroblasts will be present in the bone marrow if a marrow biopsy is performed. There are going to be a ton of anemias that you're going to be learning about in your hematology course, so I recommend putting together a chart that has each anemia, what is going to be happening with iron levels, is it increasing, decreasing, what is happening with ferritin levels, are those increasing, decreasing, etc., and other special things about each type of anemia. So for example, for sideroblastic anemias, RARS, you can see hypochromic red cells and macrocytic red cells. Hereditary sideroblastic anemias, you can see hypochromic red cells and microcytic red cells. Sideroblastic anemia caused by alcoholism, you can see macrocytes. In this type of anemia caused by lead poisoning, you may see basophilic stippling present in the red blood cells. So this was my recommendation. There are a lot of them, and it's good to get organized so you can better remember them for your exam and board of certification examination. Hemochromatosis is the last one we're going to be talking about in this lecture video. Hemochromatosis is a metabolic disorder that leads to an excessive accumulation of iron in the body. There's a huge increase of serum ferritin levels, and there's an abundance of iron in iron stores. So hemochromatosis can be genetic due to a mutation that increases the iron absorption of the body, or it can be secondary and is associated with a number of other conditions. A lot of times patients will not have any symptoms with hemochromatosis, and the disorder is usually diagnosed after a high level of iron is detected in the serum. Patients with symptoms can be weak and fatigued and can have memory loss, joint pain. Greater symptoms occur when the excess iron accumulates in specific organs. In the heart, it can cause abnormal beats or failure of the heart. Liver accumulation can cause cirrhosis, etc. Due to iron accumulations in the liver, liver enzymes are typically elevated in patients with hemochromatosis. Anemia is generally not present, but can be with this disorder. And the morphology of the patient's red blood cells is typically normal as well. The treatment for somebody that has hemochromatosis is therapeutic phlebotomy. So the more medieval term for this is bloodletting. So the phlebotomist takes out a desired amount of blood from the patient, just like if they were donating their blood. However, for these patients, their blood cannot be donated, so it's just discarded in a biohazard container. Alrighty, so that wraps up on this lecture. If you like this video, go ahead and give it a like, and please remember to subscribe to my channel for more educational laboratory content. And as always, if you have any questions about this lecture, please leave them below in the comments. I'll be happy to answer them for you. Alright, until next time.